must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show. Hey, everybody. Welcome to another episode of the HET Podcast. I am one of your hosts, and I am Brandon Powen. And of course, as always, I'm joined by my fellow co-host, Dr. Stephanie Wyrock. And today, I actually welcome one of my former DPT program professors and two NIU DPT alumni. Now, NIU representing Northern Illinois University, of course, with actually one of the guests that we're going to have on today being a repeat guest, who, of course, was Jake Awender. As in the past, he came on to talk about his sports residency training and kind of his background and experience with that. But today, we're actually going to talk about NIU's sports mentorship program that they created within the NIU DPT program, along with discussing the program's clinical readiness practicals that they had created. And so with that, I have the distinct pleasure of welcoming Dr. Brynn Rooney, Jake Awender, and Kayla Epperson. Well, thank you all so much for your dedication and, your work to bettering education and for coming on the show today to chat. And, I totally understand that there's a lot to your guys' background and stuff that I didn't really get into, but I wanted to give you guys the opportunity to introduce yourself. So would you mind just kind of sharing a little more background into who you are and kind of what's led you to where you are today? And Brynn, how about we start with you and then followed up by Jake, then Kayla after that, if that works?
Great. Thank you so much, Brandon, for having us. Really excited to be here today. So yes, again, my name is Brynn Rooney, and I am here kind of led to this point. I guess I'll start with, I graduated with my DPT from WashU back in 2010. I went on to practice in the outpatient orthopedic world, private practice for a number of years. And for the last 5.5 years have been a clinical assistant professor at NIU. So doing teaching, clinical instruction in our faculty practice, as well as clinical research, particularly in the sports related arena as well. And so up until actually this May, I had been in that position at Northern Illinois, and now I actually just left. I'm starting my own cash-based PT outpatient practice, and also actually starting an early career professional coaching, career coaching business as well in the fall of 2019. So thanks so much.
All right, yeah, and then Brandon, thanks again for having me on. So I graduated with my DPT in 2015 from NIU. Graduated in 2015 from NIU, and then went on to complete that residency at Fairview in Minneapolis, leaving there in 2016. Worked for a commercial PT company for about a year and a half before leaving there to start my own sports-based practice in the west suburbs of Chicago here. And then I heard from Brynn reached out to me last year about starting this mentorship. And that's probably the last thing I have on my resume here recently. And here I am today. So yeah, thanks again for having me on.
My name is Kayla Epperson. I'm a physical therapist and a strength and conditioning specialist. I currently work in an outpatient orthopedic clinic since graduating from NIU in 2017. I was a former college tennis player, so I have an interest in managing the overhead athlete and sports physical therapy in general. And I am currently in a tennis serve fellowship with Mark Kovacs in the Kovacs Institute in Atlanta. So I have a passion for tennis medicine as well as just general overhead athlete and return to play. And I was lucky enough to join in on the sports mentorship program with Jake and Brynn last year as well.
Awesome. Well, we're so excited to have you guys on the show today. Before we dive into this program formally, let's just kind of set the stage and start with a broad question. So, Brynn, we've heard from many students about kind of how they felt unprepared for the clinical world once they entered the workforce as an independent clinician after graduating. Now, realizing that this is a student program that's dependent on other contributing factors, what are your thoughts about why this phenomenon of students not feeling or being prepared for real clinical life environment is happening?
Sure, I think that's a great question. I think it's a loaded and a complicated question, but I think it's a really good question. I think I'll probably take it in two parts here. So I think the first part of that question about not feeling prepared for the workload of the real clinical environment in day-to-day practice right now, I really think we need to ask ourselves if part of that problem is not necessarily the student's perception or preparation, but perhaps maybe a problem with the current healthcare climate and workload in and of itself. I think when we look at that, practicing clinicians, you're not going to hear many of them associate feeling overworked, feeling stretched too thin. You're not going to hear them associate that problem with education or unpreparedness because they've been in the field for a long period of time. But I think we really do need to ask ourselves with the climate, how much quality care, skilled care, necessary care can we be providing if we're seeing 20 plus patients in a given work day. And so perhaps maybe that's tangled up with the students' preparedness and perception of preparedness as well, because I do think part of the issue is an overall healthcare environment problem as well. These practicing clinicians probably also are feeling overwhelmed and burned out and like they don't have enough time with their clients. And I don't think that's unique to new graduates entering the workforce. To take that second part of that question, though, I think that's a real good and meaningful question to ask about new graduates. And I think you have that actual preparedness and that perception of preparedness. It's interesting to me because the students are exposed to many of these high workload environments in their clinicals. So many times this type of environment isn't new upon graduation. I think there's obviously a difference between having the role of the student and then having that role as an autonomous clinician who's responsible solely for all of the care that they're delivering. I really think there's something to be said in looking at this question about, are we doing enough to develop the soft skills of our students? Perhaps, things like empathy versus sympathy, and empathy burden and caregiver burden, soft skills such as boundary setting, being able to say no, really giving them some agency in entering that workforce where they can have some more self-determination. When I talk to students and I talk to them about this issue, it's really interesting. They talk about meeting expectations, and I ask them what their expectations are. And they don't have personal expectations. They let the environment set their expectations for them. They have no idea what they think is reasonable, what they think they're prepared for or capable of doing, And so I think having those conversations about, you might have the ability to negotiate some of this. You might have the ability when you're in a mentorship program by your employer and they're rushing you through it because they're busy, to say, no, I'm not ready for that. This was what we agreed upon. And so I think we need to take a look at some of the things we haven't addressed in academics and in clinical preparedness as well. And a lot of that is the soft skills, in my opinion.
So I completely agree with everything Brynn said. That's, I think, definitely contributing. I don't have the exact answer on how to fix it or to help it, I suppose, but that's a great response. I think a little bit of it too, as far as just feeling unprepared. This is pretty simple, but I think it's also kind of normal, and it's never really going to go away, or I don't even know if it necessarily needs to go away. We do so much, like we graduate as such generalists as PTs at this point, and so no one comes out of PT school having done exactly exactly what they're going to do in their first job ever in PT. Maybe some people are lucky enough to work in the same clinical location, maybe where they just had one, but that's pretty rare. So I think, they're not ready for the load, and that's maybe healthcare climate related. And it's just a completely new job with a higher volume of usually one thing, which you just don't get in PT school. So, because I felt that way. I was really, really nervous, even starting both residency and my job after residency. Not nervous, but felt unprepared, I should say, for exactly what I was going to do. So I don't know if that'll ever go away or if it's necessarily a bad thing. I think it's bad to go from nerves to slipping into one track and complacency just to get comfortable as quick as possible and not changing. If that happens, that would be, of course, no good if that happens consistently. But I think that's all I have to add. It's probably not going to go away anytime soon.
And I'll add to that too. I agree with both Brynn and Jake on this one. I think when you're in the actual DPT program, you're so focused on developing your motor skills and proficiencies that you're not really thinking about the big picture and, an entire case, the prognosis, the plan of care, and also how your soft skills fit into that and being adaptable. You're just trying to get the basics down and thinking big picture is really hard. And then when you get thrown into it and you're seeing, the same patient, through an entire plan of care, which maybe on your clinicals, you didn't have that opportunity. Figuring that out can be challenging. And I think it's important for the DPT program to, set up practicals that kind of mirror those situations and prepare students for that. And then also having clinical experiences and clinical instructors who help develop you in that way, rather than just being, a helping hand or, an extra worker with you and allowing the students to really develop that, the entire process throughout their clinical experience.
Yeah, I think you make a good point, Kayla. Working in PT school, we're taught a lot of those psychomotor skills, but having our clinical instructors help us develop some of those affective behaviors to really make sure that we are interacting with patients in an appropriate way and being able to serve both their physical needs, but also their emotional needs. So kind of going off of that, how did this idea of a sports mentorship program start?
So interestingly enough, I was at CSM last year, and I, as a representative of NIU, had previously participated in a qualitative survey about the sports content in our curriculum. That study was published, I believe, in 2017, and then it was presented at CSM. And I happened to be sitting in a talk and listening to the current level of sports content within DPT curriculums across the country. And I was really frustrated, I'll say, and struck by the fact that 43% of the programs that they surveyed, or that responded, offered either an elective or a sole class for sports related content. So I really, there were a number of other things that went along with the data they found that struck me, but that was the biggest one. I really thought about the fact that if you walk into a general orthopedic clinic, the number of people and clinicians touching and reaching people who have sport-related concerns across the lifespan, really, and across competition levels or recreation levels, I really thought, well, that's certainly not enough. Right? So if you're going to be able to walk into your clinic, your first job, and touch a good portion of people who have these needs, and we're not covering that well enough in our entry-level curriculum, I really started thinking about that as a major problem. Pairing that with some of the data out there about second injury rates after a sports injury, return to baseline levels, I started to really look at this as a major problem in practice. I am a really big proponent of sports residencies as well. So I started thinking about that, and one of the solutions is the sports residency. However, when you look at the number of sports residencies and you look at the number of people graduating residency programs each year, there's never going to be enough, in my opinion, to meet the demand or really make a meaningful dent in the everyday clinician population that's reaching these people who have sport-related needs. So I started really trying to think of how can we make a difference that maybe has a larger ripple effect in raising practice standards, especially these new grads. That was where my reach was. I was at a university, so that was where my reach was. Really these new grads coming out and being more prepared to meet these patients that they're treating every day. And so I kind of, by the end of CSM, I called Jake and already had my idea. So it was like a 3D idea. And so really constructed this idea, and with the goals of one, raising knowledge base or increasing knowledge base around this content, raising the standard of practice as much as we possibly could, increasing some professionalism skills in students. So I had 14 students accompany me to CSM that year, and they were looking at me and asking at the teammates event put on by the sports section, how can I be like these people? Or at platforms, how can I give one of those? And really looking at what content out of a residency program can we really manipulate and bring to the current DPT student in a reasonable manner. So that was one of our goals. And the other was really building a network. So you look at Jake, Kayla, and I, and we have done clinical research and outreach and team injury screenings and all these things because we've built a network of, sports clinicians. Jake, I have my SCS, Jake has his, and Kayla's sitting for the exam in the coming year. And so when you look at that network and the ability to call people and say, I have this client and I'm not really sure what to do, I thought, there's a way we must be able to do this on a smaller scale that is going to have a reach that grows beyond one or two graduating residents at a time.
Yeah, I think that's a great point, Brynn, and especially given some of the other constraints that can exist with, of course, looking to do more of a formal program and even doing it more formally with the university. Of course, how do you squeeze more stuff into a curriculum? And plus, there's also cost. Not everyone can afford to go through a program. Not every program can afford to put on a kind of program or dedicate that much time and money to an initiative like that. So I think that's a really good way to get around it, because we've been seeing more prevalent are certainly these more elective run classes or kind of outside options to really hit at these developing areas, which I think is great. I mean, it's addressing the issue to some degree, so I'm all for it. But let's dive a little bit deeper, Brynn, into what specifically does this program entail? Like going through like the application process, the didactic component lab, like let's just cover all the bases. What does this program specifically look like?
Sure, great. So we had extended our application to our current end of first year and end of second year students. So going into their second and third year of a 3-year program, they had to apply, create a resume, which I found out many of the students didn't have. So it was a really good developmental opportunity for them. They had to create a residency, a personal statement, and then sit for an interview. And I actually had Jake and Kayla run those interviews. So I removed myself as sort of a faculty member and really only weighed in if necessary. So they went through an interview with Jake and Kayla, and we sort of modeled that off of the residency interviews that we've been exposed to or have some knowledge of, just the process in and of itself. So again, if any of these students wanted to move on to that level, again, they're getting more comfortable with their interview skills. So we took 6 students for going into their second year and 2 going into their third year. And we had monthly meetings. So our meetings consisted of both lecture and didactic content as well as lab application content. And then each of the students was responsible for leading. They were paired up with a mentor, So I had 3 direct mentees. Kayla had a mentee and Jake had 2 direct mentees. And so they were paired up, and each of us helps them create and lead a journal club. They had to also do a community outreach. So whether that was attending an on-field experience, doing some sort of screening, we did Special Olympics screening, baseball practice, they came and observed on field with us. And so a number of different getting themselves out there in a different experiential way that perhaps they don't get in their current model, in their current content. And then they all, 6 of them had to present a 30-minute platform presentation. So this was modeled kind of between a platform you might see at CSM, but a little bit longer that maybe they would be giving in a residency program to really develop their professional presentation skills. So that is kind of the whole. I don't know, Jake and Kayla, if you guys have anything, if I missed anything or you want to jump in.
I love that you are incorporating public speaking into this mentorship program, because in my experience teaching students at a CI level, all my students are nervous to present in front of 10 people. And like as a physical therapist, this is a very important skill to have, especially if we're going to be leaders in healthcare and we're going to disseminate our information as physical therapists to the general public. So I admire you for incorporating that public speaking component into your curriculum.
Thank you. It's really interesting, actually, Stephanie. So we took some data on our mentees pre-program and post-program, just about their confidence level, their knowledge level. And we actually, for program assessment, took data on as a kind of control on our third-year students who were not part of the program. One of the things I found really interesting was the students who were in the sports mentorship program, their self-perception of their ability to give a presentation was different than the students who were not in the program. And I actually think the students who were not in the program perhaps maybe had an elevated perception of their ability, where the students who went through the program actually really learned about how much more went into giving a presentation and how much skill they still had to develop. So the students who didn't go through the program had a higher confidence rating when they were surveyed. And I really think that's interesting, because if you talk to the students who graduated the program, they are absolutely, they either strongly agree or agree now that they're able to give a strong presentation. But that wasn't always the case. And it was an interesting comparison between the two groups, and maybe some lack of self-awareness.
That's a really interesting statement. I wouldn't have expected to see that in the data. What do you guys think the strengths of this mentorship program are?
I think that one of the biggest strengths of the program is that it's very unique and there's nothing like it, especially in the state of Illinois across programs. So like Brynn was saying, I think the students that were involved in the program had, this bigger perception of themselves, like we're in like this more of like this select group, and we have this special opportunity to be part of, this new program that's not offered elsewhere. So I think that was a big strength. I think Brynn modeled a lot of the curriculum based on the current sports residency curriculum. So I think that was, fairly comprehensive considering the amount of time and contact we had with the students. And I think that another strength was that Brynn, being faculty, she had a very, different perspective to bring to the table as far as teaching and, more of the didactic learning and lab content. Jake actually went through a sports residency program recently, so he had that perspective. Then I haven't completed a sports residency, and I was, just 1 year out of the NIU program. So I think we all had, unique perspectives to collaborate and develop the content and from all stages of, the process and being involved in sports physical therapy.
Yeah, one thing that I thought helped a lot and was interesting, a dynamic, was all three of the mentors, myself, Kayla, and Brynn, obviously come from like different backgrounds, especially even as far as our sports exposure. So Kayla, I believe, played tennis at a fairly high level, overhead athlete. Brynn swam, played water polo at a fairly high level. I was more football at a much lower level. But I see baseball now. And so that's all, if you're just at least just to cover the overhead athlete, that's 3 sports, male, female, stuff like that. And I think the mentorship turned out to be what we at least said it was going to be, or claimed it was, or labeled it as. It wasn't more school. We didn't try and make it more just schoolwork. And we had no, we weren't trying to make it even a residency. It was a mentorship. There's a lot of access to us for the mentees. Lots of exposure to different ideas and things, and lots of discussions. All the mentors, I will, correct me if I'm wrong, so I'll speak for you guys here. I think I learned a ton. I think everyone did from each other. Nobody came into it with, I'm going to tell you how it is, an ego, anything like that. We learned from the mentees. We learned from the guys. We had to look stuff up when they asked. We had to talk to each other. It was great. I think that was a big advantage. And I think it just exposed them to a lot of different areas or different ways to go at the same problem, stuff like that. And that comes just from our different backgrounds. If we had a fourth mentor, it'd probably be even more of it. So it wasn't just us. I think it was just more the way it was set up. But it worked. I think it did. I think it worked great for its first year.
So I think kind of piggybacking off of what Jake said, and I agree, by the way, that I learned quite a bit from the mentees as well. But piggybacking off of what he said, I think it was really good for the mentees to see three clinicians agree about things and disagree about things. I think, a lot of things we took were case-based. So maybe it was
usually right.
Somebody was actually, that a client somebody was actually seeing at the time, or a previous case. And it was, I think, really good for them to see, okay, well, we don't know the answer to this in literature or in best practice. There's debate about it. I would approach it this way, and Jake and Kayla might approach it a different way. I think students get hung up often on any time there's any sort of dissonance academically in clinical practice. And I think it was really great for them to see that we disagreed, that we were talking about experts who disagreed, and get a little bit more comfortable with that. The second thing I was going to add was that going back to the speaking and the journal club leading, as a faculty member, one of my big struggles was always to get students to give meaningful and authentic peer feedback. And so I felt that one of the surprise outcomes for me was how good these, and they were all gentlemen, so these guys got at giving authentic peer feedback. So when they were preparing or practicing for their platforms, I was wonderfully surprised at how, picky they were at providing feedback on things that you normally didn't see, or at least I normally didn't see in our program of giving peer feedback. And so that to me was a really unexpected, great outcome that I think was a strength of the program. And maybe it was the size, maybe it was the comfort level. Perhaps, I'm not really sure, but I thought the more and more you can give authentic feedback, the better everybody is.
Absolutely. And I love how so many avenues of this program hit that so many avenues to really help develop these students into really well-rounded, effective clinicians, and also speakers, and even good critiquers. I think there's so many pros that these students are getting from that, and I love it. But of course, we have to also play the other side and say, given based on the feedback that has also been given from current students, what are some things that you guys think could have been improved on when it came to the mentorship program? And what were some ideas that you guys had that were kind of meant to address some of those areas for improvement?
I would say a little bit we got this from feedback, just because it's hard to deny, and it's just easy to see ourselves needing to fix this. But like the organization of scheduling meetings around clinical rotations was probably, I don't know what you guys think, actually. This is an interesting question. Was probably one of the bigger things, though, because we ran into some guys being out of state for a clinical. It's like, oh man, now we planned these meetings back in May, and now it's November, December, and people are gone. And they have no choice; they can't make it, and how are we going to do it online? So kind of seeing that stuff coming a little bit earlier, or maybe changing the way we do some stuff, would maybe help. I know the guys agree with that. I don't think it was a problem necessarily. Like it just wasn't. It could have been more efficient. So it was a problem. I think it just. We handled it okay. That's probably the biggest one that I see, because as students, it's hard to say, oh, we can do more of this, more of this, more of this. Again, we're not trying to make it more school, and traveling for them is hard. They're completely broke students. This is not a postgraduate paid residency position where you get enough for at least gas. So we're kind of limited in how we can, when we can meet, but planning it ahead, I think it would be, it's going to be more challenging, but I think we can do a little bit better at that in the future. I don't know, Brynn, Kayla, what do you guys think? Yeah.
I would agree with that. So one of our challenges is we took students from multiple years in the DPT program. And so the clinical rotations didn't match up when they were present or away. And so I think that was perhaps something that we could do differently, and maybe we offer it a certain year. I'm not really sure, but that is one solution, because then there's less changing of the scheduling. I, as a faculty member, wanted to be really cognizant of their workload, because I see students who are overworked and overstressed, all the time. And so I wanted to make sure that we were respectful of their demands in school at the time and their clinicals. So I think looking back, we can definitely modify the scheduling and perhaps the makeup of the program. I think that is certainly one. And I think there's something to be said for how much independence do we give the students? That's always the question, right? So there were things like they were supposed to be doing these community outreach, and if they wanted to do more, they could. We didn't, it was a lot up to them. We didn't say, oh, checklist, have you done this, right? It was an independent learning opportunity. So if students came to us, we facilitated everything and anything they wanted, really. But we weren't sitting there. So I guess if somebody's not going to put their work into it or really take advantage of their opportunities for any one of many reasons, school got busy, they have personal stuff going on, or whatever it might be. I think the challenge is always how much oversight is there, and how much do you just say you're an adult learner and this is an independent opportunity.
Yeah, I'll piggyback off of Jake and Brynn here. Again, a lot of it was the scheduling and timing and being able to be consistent throughout the entire program. I think another thing we could have improved on was just point of contact. We were giving them a lot of independence, so there wasn't a lot of structure on, how much can you reach out to your mentor, or like how much should the mentor be reaching out to their mentees, and checking in with them and utilizing that mentorship relationship. And so I think, some of us developed, more of a schedule with our mentees, but in others, maybe the students weren't utilizing us as much as they thought they could, just because there wasn't a true structure around that relationship.
I also, one last thing, would say it's an interesting makeup, because I was a faculty member at the time for the students. So I think one of the strengths we didn't touch on was having academic mentors. So I think one of the things we could have done on the front end is, again, I took 3 of the 6 students as direct mentees, and really letting them know, and we did this, but I think we could have done it in a stronger way, letting them know that you don't have to just reach out to your assigned mentor. I think students perhaps at times, I imagine, felt more comfortable reaching out to Kayla and Jake, because there wasn't this I'm seeing this person in class tomorrow relationship. And so I think making sure that they understood whether it was a direct schedule with their mentor, but that they always could reach out to any one of us.
I think you guys make some really good points there. Brynn, do you know if there's any evidence on formal mentorship programs like this within healthcare education?
I do. So I'll say first and foremost that it's generally pretty sparse. Most of it is done in the medical fields, and by most, there's still not a lot. So I think in 2000 to 2010, there was 11 papers on mentoring and formal mentorship programs, and even some of those programs were more informal. I'd say in the last 5 to 10 years, more is coming out, but still I think it's at a very, pilot level. Certainly I don't know of much as it relates to physical therapy. I think what's really interesting, and one of the ones I really liked, was in 2010, Stanford developed a professional committee for professional support and satisfaction for their physicians, and then realized that, so they did this because they realized that personal satisfaction and professional fulfillment was really directly tied into quality of clinical care, safety, and patient-centered care. And they started this program and then realized that they really were missing the boat. And they needed to be getting their medical students in on the ground floor and not just their practicing physicians. So they have a really nice model where they pair 6 medical students to one mentor for the duration of medical school, really aimed at trying to develop both their clinical skills and their professionalism, increase research interest, and honestly do some support in personal growth of the students. So that was a model I really liked because it was actually tied specifically to quality of care and satisfaction. And so I think it's coming. There's not a lot out there, and I really don't know much of it in physical therapy. I think a lot of it is tied to the employer and employer mentorship programs, which exist, but from anywhere on the spectrum of formal mentorship to informal mentorship. And really many times I truly believe that a lot of the programs that are proposed aren't executed the way that they're proposed even as it stands.
Well, and I can actually kind of comment a little bit on the PT literature as mentorship goes. And one of the things that they've done in some of these qualitative studies in PT is that mentorship helps to make students have more affinity for professional development, care more about the profession, and pursue leadership opportunities within the profession of physical therapy. So I think that, the fact that you guys are offering something like this at your university is really quite important, because it's going to help make those students that are involved potentially more apt to be in leadership positions within APTA or within their state or association.
We saw that in our data as well. So some of the questions that the mentees post-program rated more strongly or more agreement with were things like that they felt the ability to contribute to the sports physical therapy clinical research. They felt comfortable discussing topics with local, regional, and national sports physical therapy leaders. They felt prepared to contributing to enhancing sports physical therapy best practice. So some of these things where they were wanting to take on. Another one was they wanted to become a mentor. So I think we saw that in our own data as well. And certainly compared to their peers, or even sometimes compared to some of the third years, if we're talking about the second years who had a whole year of more of education, and our students were rating themselves higher or agreeing more with some of these statements. So we certainly saw that as well.
Yeah, and Brynn, I have one follow-up to that. Given your experience and kind of your role in developing this program and seeing all the things from your perspective, what would you ideally like to see more of the research focus on in regards to these programs? Like what ideally what are those burning questions that you'd have that you'd like someone to kind of dive more into to help at least clarify the waters a little bit? Oh,
that's a great question. So I think a couple of things. So to what Stephanie, what you alluded to in the PT research, I think, that exists and is starting to grow in robustness. I still think we have a lack of formal programs, right? So evaluating if somebody has an informal mentorship or relationship with a clinician, or they have went out and they sought their own mentor and they, have perceived this relationship as mentorship. Are those outcomes different than a formal program? So I think that would be one question. I think like anything, Brendan, I would say longevity, right? So long-term outcomes, like anything in healthcare. I'd like to see long-term, if people go through informal or formal mentorship, are they really taking those leadership positions and involved more, giving more presentations across 5-10 years down the road? And then, of course, like anything, are outcomes different? Are patient and clinical outcomes different? Because that's really what it's about at the end of the day. If I can give a great talk, it doesn't matter if I can't have good clinical outcomes. Then I really shouldn't be practicing if that's the case. So I think long-term outcomes, both within professionalism and the clinic, I think would be the biggest things for me.
Yeah, no, I mean, those seem like really, really great points on that. And Jake or Kayla, do you guys have anything to add on this thread?
Yeah, I just listening to you guys actually. So first of all, I will use this as an example of saying I'm not afraid of it. I do not know. I'm not that familiar with the literature on this. But listening to you guys talk, it's probably, I'm sure it is hard to tie, let's say, a mentorship, even a residency, to clinical outcomes in sports. Sports is a specialty, but it's also an extremely vague word, you know? So how could, it would be hard to say this person's outcomes or this program produces better outcomes in care over even someone that's not spot, you know, who are you seeing? What's the problem? How severe, blah, blah, blah. What's the sport? The list goes on. So that's just a good question. I'm just mostly thinking out loud. That'd be really hard to do. So I'm actually almost not excited, but it's very interesting to hear the data they do have on people that are more willing to become involved and stuff like that. That's kind of big. I did not know that because I've also wondered, there's one study, I couldn't cite it right now, but I did read it back when I was applying for stuff. I think it was orthopedic residencies, but they did not have better outcomes. And it's like, oh man, well, why not? Well, it's just an orthopedic residency, that's broad outcomes of what? It's just a hard thing to tie together. So not that you should start digging for data to support your hypothesis, but it's nice to hear that there is something coming out of it that's hopefully a bit more consistent as time goes on.
Yeah, and I'm assuming, Jake, you're talking about the Rodeghero study that kind of looked at the residency and fellowship outcomes. And
yes, that one.
It is interesting. I mean, I think given when you really look deeper at that study, I mean, while it is interesting, we certainly can't make a broad generalization with that because that was kind of the first of a kind of study like that. And there were so many other variables in play that are really hard to make a definitive thing. But I think it was interesting is there was a recent one that came out not too long ago looking at perceptions of fellows after graduating from a fellowship program. And it was really, really interesting just kind of looking at the differences that they had self-perceived following. And just, you know, and we still need a lot more research on that. And it's going to be very hard to narrow down specifically. So like you had kind of mentioned, so that's a completely valid point. But yeah, I think the research on this avenue is still in its infancy for sure. Kayla, do you have anything you wanted to add into this as well?
Like Jake, I'm familiar with the literature and current mentorship programs, but I think Brynn raised a good point in being interested in understanding, provided or structured mentorship versus mentorship that you seek out and like cultivate more naturally in a relationship. I think that would definitely, be interesting to see the data on that. But I think more than anything, data or no data, I think that in the sports physical therapy world, networking is super important and it's all about who you know. And so I think what's unique about having this program is just the ability to increase your network and then, cultivate relationships with other people in the profession and using us as kind of lifelines of who we have known and developed relationships with and just, fostering more of that collaboration across our entire program.
Yeah, and if I can jump back in, I'm kind of hopping around here, but we started the podcast talking about people or graduates kind of getting, don't remember how the question was phrased, but getting over like that first job kind of nerves thing. And then to see just the way you guys are talking about the data, how they're more confident they're in their skills after fellowship, stuff like that. So if you can kind of bridge that, I don't know what I'm doing in my new job feeling to, okay, I'm confident that I can help this person, treat them, refer them, whatever. So I don't know, maybe there is some kind of a connection there and a benefit, I hope. But I'm just thinking out loud again, I find that very interesting.
Well, absolutely. And this gets back into a lot of the research that's been done looking at clinicians' beliefs and clinician confidence. So Chad Cook, of course, looking more into equipoise and seeing how some of these non-specific effects and these attributes can certainly influence an outcome. So, I mean, it's certainly not all of it, but it's certainly a big part of it that is certainly very powerful. So yeah, Jake, I think that's a really solid point to add into that because it is certainly relevant. And Brynn, you kind of had touched on this answer a little bit earlier in the episode, but I want to kind of get kind of your formal rationale and kind of thought process in terms of why or why not would you consider turning the program into a formal residency? Like, let's just kind of dive through some of the troubleshooting and some of that a little bit more in depth, because I recognize that, of course, APTA and there's a lot of other things that want to see that improvement in sports residency sites to be able to accommodate that. But let's also have an honest discussion about how that actually looks as well.
That's a great question. So I think it speaks to how we started the program from the beginning as well. So from the time of CSM to the application, beginning of applications was really like a month and a half. And so starting that program with the least amount of red tape was, I think, really meaningful in some ways, because we were able to reach people where we probably still wouldn't have had a program if we were building a residency or going through letting other agencies or university departments kind of run and say how this program was going to work. I went and got approval from somebody in a position to approve, and we ran with it. And that was really unusual, I think, in academics. So that was actually really nice. I think turning it into a residency, like I said, I think the amount of support required, whether that's external site support, in sports world, on field, training room access, the amount of support needed to run a residency for 1 or 2 residents every year is a lot. And so really, honestly, this program ran on my and Jake's and Kayla, thankfully for them, their volunteer time. And so I think we were able to really reach 6 people in a way where one of our previous mentees just reached out to me and wants to start a journal club with the greater body of the DPT program, a sports club for all those people who maybe aren't in the program or haven't enrolled. And so I'm already seeing effects that perhaps maybe I wouldn't have if the residency route was taken from the beginning. That being said, like I said, I'm a big fan of residency and fellowship training. I really am. I think it speaks to, like you said, some of the intangibles that maybe aren't easily captured in the research. But I think for us in Northern Illinois, where DeKalb is located, there's just not a lot of resources. And I didn't want to delay operationalizing this opportunity to go through all of that.
No, it makes sense. And especially given the changes that have been going on with residency and fellowship accreditation and candidacy regarding all the paperwork. I mean, that's just one avenue of it. Like you said, there's a lot that goes into it that takes a lot of support and needs a good team to be able to efficiently do that, to cover the bases. So I completely concur with that. And you had mentioned, of course, what you had to go through, of course, to kind of get that off the ground from the university side. But let's just assume, let's hypothesize here. Let's go back in time. Let's rewind the clock. Let's say you didn't have it that easy. Let's say initially when you're presenting the idea, you kind of ran into some issues or some hesitancy with doing this. What would be some tips that you'd recommend, say if some other faculty members in a similar situation, what steps or things would you want to consider to help best pitch that to the administration of the university to make something happen?
That's a great question. I would say try and design it the best you can with as little external influence from the beginning. And perhaps maybe that's a little bit, backhanded of me. However, I think it's easy to mold something into fitting the university after the fact. Once you trial it and know how things are going to run, we have a way better understanding of what we need, what we could do, what we couldn't do, now that we've done it once. So I think if you can get it off the ground and run a pilot or try and then integrate it more with the university, I think that's a really great way to go, because you have a little bit more ownership and flexibility from the beginning. I didn't have to apply to put this in a catalog and then you're bound by what that says. I was flexible. I was adaptive in that sense. I also think be ready just to volunteer your time. I mean, this wasn't something I was paid for. It was just, let's do it. And I got support. But now if I wanted to make it into something else, I have data to show how useful it was and how much the students wanted it. And I think that goes a long way in any university setting.
So Brynn, I know that, of course, NIU has also implemented, apart from the sports program, more clinical readiness, clinical preparation. Would you mind expanding on what these practicals are specifically comprised of and kind of when they're formed and kind of what they consist of?
Sure. So one of the things I'm really proud of in the NIU program is our responsiveness to our students' performance. So really looking, when we started this, we looked at our students and we looked at their psychomotor skills, their motor skills, and really looking at, were they reliable and repeatable and valid in their measurements and their skills initially? Were they comfortable, or were they inefficient? All of those things. And so we started this initial clinical, we call it a clinical skills check. And so it initially developed to really just assess their psychomotor, basic clinical assessment skills and psychomotor skills. We have evolved from that. So now our students, again, are a kind of a 2.5-year program. So at the end of their at the beginning of their second year. So this is a year after they've taken their basic clinical skills coursework, and about 10 weeks prior to their first clinical, they have to do a clinical skills check. And for the second years, it's all just basic skill preparation. So they have to perform some of these skills they pick randomly, and all of their basic assessment skills from, measurement or transfers or whatever it might be, vital signs, and they just have to be prepared. And it's pretty stressful for the students preparing for that. But what we've seen and heard both from the students and our external CIs is our first clinical students are getting really great feedback, because 10 weeks prior, they go through all their assessment skills, they're tested on all of that, they remediate any, inefficiencies they have. And so they can spend that first clinical on higher level learning, rather than I haven't taken a knee flexion goniometric measurement in a year and I'm really nervous about that. So that was really great. We then evolved our students at the beginning of their third year to make it case-based and multi-system based. So they pick a case, and it might be somebody who, is in subacute after a myocardial infarction, or it might be somebody who has an exacerbation of MS that's in an outpatient scenario, any one of any kind of case scenarios, and they have to create a prioritized clinical exam. And so that is more based on skill, but reasoning behind your skill and ability to integrate and be patient-centered. So that's how it's been in the past. I think they're talking about maybe doing away with the case-based third year one, because we have now 4 case-based comprehensive practicals within the curriculum. And so in their orthopedics, their cardiopulm, their neuro, and their pediatrics class. So we think maybe at this point, we're trying to assess if that's still really necessary. Like I said, I'm proud at the responsiveness and saying, we did this for a reason, and is the reason still meaningful?
Yeah, and do you agree with that decision?
I actually was a proponent of that decision.
Okay, good.
So I do. I think what we have found is students in general are so high stress, a lot of it perhaps externally imposed, but a lot of it internally imposed too. And we found this clinical skills check was really increasing a lot of anxiety that maybe was taking away from some of their coursework and interfering for the first couple of weeks of the semester. And so we found that the reason we implemented these, we didn't have case-based practicals within coursework when we implemented these. So now we have those 4, and they're across systems and across the lifespan. And so I really do actually think that what we're getting at, we're capturing in other places. I still am a proponent of the second year clinical skill set check, so that they're really prepared for their skills and again, can divert more attention towards higher level learning rather than skill performance.
Well, guys, I appreciate the insight, because it's been really interesting learning all the ins and outs of this program. And, I hope that other faculty are listening to this and kind of at least thinking about this for a potential option, because we all know, Brynn had mentioned from that data at CSM, that some areas within a curriculum just may not be appropriately represented due to a lot of other factors. And this is one way to help contribute to that. But we have to finish up every episode with this big final question. And the question is, if you could change one aspect of healthcare education, physical therapy or otherwise, which aspect would you change, and how would you change it?
I think the biggest thing I would change would be offering more of these elective type experiences, and then having students seek out their ideal clinical experience, because that's where I felt like I learned the most, during DPT school, is what I learned on my clinical. So like taking ownership and seeking out a challenging clinical in an area of interest really helped me make that transition from, the DPT to, professional clinician. And I think, oftentimes in choosing clinical sites, sometimes students are, looking for the most convenient location, or I have to fulfill this requirement. But when I was able to set up my own clinical experience, that's when I found the most value and got the most experience in order to make that transition.
I will say, I don't know how one would necessarily do this. I would actually like to see more specialization in physical therapy. So we'll just stick with that. I know there's obstacles, salary, if you're going to do a postgraduate residency, that's salary and time. And then loans have to get paid. So a lot of financial issues mostly probably go along with that. But if we could just set those aside for a second, I think we're a little bit behind. I don't know of many other professions, not physicians, but doctoral healthcare professions that have such a small amount of specialization. And I know we have them, but such a small emphasis placed on them. I think there's a lot of people, I wouldn't say, let's just stick with sports, that athletes are underserved. I think they're kind of disserved, because you go out in the real world away from all this, where everyone wants to, do all they can for their passion and stuff. It's not everyone's like that. Sometimes I'm the therapist that's been here the longest, and I like seeing athletes. So I'm going to see the athletes. I don't care if you're an SCS. And well, that's the person that's not the most qualified maybe, but they can still do that in PT, and you can't do that in a lot of other. I work, again, I know I said this last podcast, I work closely with some of the surgeons. You can't do that in surgery. And I know we're not going to hurt people as badly as they can, so it's maybe more necessary. But anyways, long story short, I'd say more specialization, maybe get in school on a track. You can apply to get on this track as a student, and then you graduate with an emphasis in this or that. That would be really nice to see, I think. There's a lot of people in general population, so I realize there's a volume demand, et cetera. So anyhow, more specialization, I think, would be fantastic. Vestibular therapy, I think, is great for that. You don't just toss a therapist, someone with vertigo, I hope. I don't throw them to me. I wouldn't know what to do anymore. So there's vestibular therapists that do a great job. And I think we can do that in other areas for sure. So that's what I would go for this time.
Right. But then, Jake, you're also bringing up kind of a big elephant debate as the generalist versus the specialist.
I agree. And I hope school can take care of that, because school still does its job. And you can argue about the length of the school necessary to graduate as a generalist. 3 years is a lot for what we get. I think that can still be taken care of as a student, and also continue on educating yourself as a professional. MDs still have to do that. You can't miss something basic just because you're so there's still an element of responsibility to know the basics and refer out when needed.
All right. So, I either think, to take Jake's last answer, either undergrad or how we initialize physical therapy education from the very beginning with new students. So I think under the umbrella of supporting explicitly personal growth, I think is what I would change. So if you think about how people get to enrolling in physical therapy school, education now has become, in my opinion, my strong opinion, a process of achievement. It has become get this grade, get this GPA, have this leadership position, and you're achieving and you're achieving and you're achieving. And as a faculty member, a lot of the courses I taught were within the first year. So I would see early SPT students and say, okay, so they're still in this achievement mode, and they have a really hard time embracing learning as a process and not as an outcome. And so it would take a semester or 2 semesters for them to really embrace learning as a process, which means failing forward, which means being uncomfortable, and all these things that they didn't really cultivate leading up to PT school. And I would think, like, if you embraced this 6 months ago or 3 months ago, the amount of foundational material you would have retained or the way in which you would have interacted with foundational material would have been very different. And so whether that's, in integrating that at the beginning of a PT program, whether that's the lead up for the application process or undergrad or the educational system as a whole, I really think, again, those soft skills and thinking about embracing some of the things that we don't really promote in the process of applying to physical therapy school.
No, I think that's a really good point because I can speak for myself here of going through the application process and finishing undergrad. I was so worried about grades and just getting the grade and getting all these things done because I wanted to get in. And I knew that was going to significantly help my chances, that I didn't realize that it could have hurt me down the road. So I think that's a very, very good answer. But I definitely like the idea for sure. And I really appreciate, the insight that you guys have brought today to discuss a lot of these topics. And I'm really hopeful, and I'm sure that our audience will as well. But, I recognize that some people, of course, may want to follow up with any other one of you guys just to kind of touch base on what was talked about. So where can people kind of follow up or reach out should they have a question for you?
So you can find my email on my website, myptdifference.com. My email's on there. And then my Instagram, what do you call it, a tag? I don't even know. My Instagram name is next_step_physio. The name of the practice is Next Step Physiotherapy. So that's where you can find me.
Well, Jake is actually called a handle, but you can find it there. So people can message me on LinkedIn, Kayla Fujimoto Epperson, or I'm on Twitter at Kayla Fuji Epi.
And I'm actually in the process of transitioning all of mine because, like I said, I'm starting a new business for clinical practice as well as mentoring. So by the time this airs, I would imagine that you could find my information on my website, which is withinreachhealth.com. And on Instagram, it's bnalick. And I imagine perhaps my professional Instagram as well. So.
Well, perfect. Well, all thank you so much for your time this morning and for coming on the podcast to share your insight. It's been a pleasure.
Thanks for having us on, Brandon. It was a lot of fun as usual.
Mm-hmm.
Thank you.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available on our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.